So, what happens when you take, the exact same hyaluronic acid that people use to plump their lips on a random Tuesday afternoon,
Right.
and you pair it with this promise of zero downtime, but you inject it directly into the anterior vaginal wall?
It's definitely a massive shift in how we think about these treatments.
It really is. So today we are doing a deep dive into a very specific intersection of aesthetic and functional medicine. We're talking about the G-Shot or G-Spot amplification.
Yeah, and we are looking at a fundamental shift in application here. I mean, across the board,
Yeah.
moving the focus of these biocompatible fillers from visible external aesthetics to, internal sensory enhancement. It involves an entirely different set of physiological variables.
Right, which brings us to our mission for today. We want to really cut through the clinic marketing and look directly at the medical protocols, the procedure overviews, and the post-care guidelines to answer two highly practical questions for you, the listener.
Because you really had to dig past the glossy brochures for this kind of thing.
Oh, absolutely. So first question. Is the claim of zero downtime an actual biological reality, or is it just clever marketing spin? And second, what is the actual physiological reality of post-procedure spotting?
Because, the marketing materials surrounding this procedure, they do make some pretty aggressive claims, particularly regarding the ease of recovery. So we really need to look at the cellular and anatomical mechanisms to see if the human body actually supports those claims.
Right. So let's start with the physical mechanics because, understanding the recovery requires us to know exactly what the body is enduring in the first place.
Exactly.
The procedure involves injecting a biocompatible filler, so either hyaluronic acid or medical-grade collagen, into the anterior vaginal wall, specifically targeting the G-spot.
Yeah, and the intention outlined in the clinical data is purely volume expansion. The G-spot is a highly sensitive cluster of nerve endings, right? And it
Hmm.
forms part of the internal clitoral network. So, by injecting a soft gel matrix into that very specific tissue, the provider is increasing the physical prominence and the surface area of that erogenous zone.
Okay, let's unpack this because instead of the usual, clinical descriptions, I kind of look at this more like plumping a flat pillow.
Oh, that's a good way to put it.
Yeah, like you're just adding volume so it's easier to find and utilize. If that cushion is a bit deflated, you add the stuffing to give it more structure and bounce.
That structural elevation is really the core mechanism here. The clinics aim to create a distinct, palpable augmentation. Usually they're aiming for roughly the size of a 5p coin, or maybe a quarter-inch in height.
Wow, okay. That's pretty specific.
Yeah, and by pushing that tissue outward, they are mechanically decreasing the distance between the nerve cluster and the point of friction during intimacy.
Which makes sense mechanically. But looking at the procedural timelines, the patient is in the chair for maybe 15 to 30 minutes tops. And the actual injection itself only lasts about 8 seconds.
Right, it's incredibly fast.
But wait, if we are talking about forcing volume like a needle and a thick gel into one of the most densely innervated tissues in the female body, how is this not just an incredibly painful ordeal?
Well, the feasibility of this procedure happening in a standard clinic chair, rather than an operating room, it entirely comes down to specialized anesthetics.
Okay.
Before the syringe is even prepped, a provider applies a highly concentrated numbing agent, usually a lidocaine-based cream, or sometimes they'll do a local block directly to that mucosal tissue.
Right, and lidocaine works by blocking the sodium channels in the nerve endings, doesn't it?
Exactly.
So it essentially just halts the pain signals from ever traveling up the spinal cord to the brain.
Yeah, it creates a temporary chemical blockade. And because the mucosal lining absorbs topical agents so efficiently, the tissue becomes completely desensitized to sharp stimuli almost right away.
Oh, wow.
So during that 8-second injection, the sensory receptors literally can't transmit the feeling of the needle piercing the tissue.
But they can still transmit pressure, right? Like you would still feel the physical expansion of the tissue as the gel goes in.
Yes, exactly. You feel a blunt, heavy pressure. The gel displacing the tissue registers mechanically, for sure, but not as acute pain.
Okay, got it.
And this lack of severe pain signaling is the first crucial component in understanding why the body doesn't trigger a massive trauma response. There are no incisions, no tissue being excised, no scalpel, and no stitches required to close a wound.
Right.
The body is just simply accommodating a soft, flexible substance that's being introduced into the existing extracellular space.
Which brings us perfectly to this concept of the lunchtime procedure.
Yeah.
And I want to aggressively challenge this idea for a second.
Go for it.
Because Clinic brochures constantly tell you that you can walk out of the office, grab a coffee and go sit in a 2-hour boardroom meeting. But let's be real functionally, putting aside the marketing gloss,
Yeah.
can you really go straight from the stirrups back to a boardroom meeting without needing an ice pack?
Well, the clinical consensus actually says yes, you can. Really?
Yeah, and what's fascinating here is that the reason this is possible requires us to really separate systemic trauma from localized microtrauma.
Okay, so a systemic response would be what happens after, like, traditional surgery.
Mhm.
So if you go in for an appendectomy or even a surgical cosmetic lift, a scalpel is physically cutting through multiple layers of fascia and muscle.
Exactly. And in response to a scalpel, your entire body essentially goes to war.
Right.
Your immune system triggers a massive cytokine cascade. White blood cells flood the bloodstream. You get widespread inflammation as the body tries to prevent infection. And your metabolic energy is entirely diverted to healing that severed tissue.
Oh, for sure. That systemic shock is what leaves you feeling exhausted, feverish, and just completely physically depleted. Like, you need bed rest because your whole system is working overtime.
Precisely. But with the G-Shot, we're dealing with a 27-gauge needle and hyaluronic acid. And hyaluronic acid is just a glycosaminoglycan. It's a sugar molecule that the human body already naturally produces in our joints and our skin. Right, so because it's bioidentical, introducing it doesn't trip those immune alarms.
Right. The immune system doesn't register the HA as a foreign invader to attack. And furthermore, the physical work of the augmentation is completed instantly. The moment the gel is injected, it begins binding with surrounding water molecules, plumping the tissue on contact.
So the body doesn't have to launch a systemic healing response at all. There's no cytokine storm, no widespread inflammation, no metabolic drain. The lunchtime claim actually holds up, not because it's magic, but because you bypass the systemic trauma response entirely.
Exactly. The only physiological hurdle you face when you're walking out of the clinic is a lingering, heavy numbness from the lidocaine, which typically metabolizes and wears off within just a few hours.
Okay.
And once those sodium channels unblock and normal sensation returns, the sources indicate you might feel a dull internal ache.
Yeah, I saw that the materials often compare that aftermath to the feeling of a routine pap smear. A slight tenderness, a feeling of internal pressure. But certainly nothing that demands prescription painkillers or, like, lying flat on your back for 3 days.
Right, because it is entirely localized. You can sit in that boardroom chair because your immune system isn't demanding you go to sleep to heal a major wound.
Okay, but even without systemic shock, we are still talking about a needle puncturing internal tissue. A localized puncture is still a puncture.
Yes, it is.
And looking at the post-care FAQs across all these clinics, they universally plan for the patient to experience minor spotting. They often even provide a sanitary pad immediately following the injection.
Yeah, and spotting is just an anatomical inevitability with this procedure. The anterior vaginal wall is remarkably vascular. It contains a really dense, complex network of capillaries that are designed to facilitate blood flow and engorgement during arousal.
Right, so anytime a needle passes through a highly vascular zone, it is mathematically guaranteed to intersect with at least a few of those microscopic blood vessels.
Exactly. The needle breaches those tiny capillaries and minor bleeding occurs. This is not indicative of a complication or tissue rejection or a poorly executed injection.
It's just biology.
Right. It's simply the physiological reality of moving a sharp object through vascular tissue.
Hmm.
But the capillaries quickly constrict, and the localized bleeding typically resolves on its own very rapidly.
Which raises a highly practical question for anyone managing that localized bleeding.
Okay.
If you leave the clinic and you're spotting, inserting a tampon might seem like the easiest solution, right? But considering you just had a carefully placed filler injected to create a very specific volume and shape, wouldn't a tampon pressing against the vaginal wall risk, like, flattening or displacing that filler?
It's a great question, but the medical guidelines actually confirm that tampon use is entirely safe immediately after the procedure.
Oh, really?
Yeah. And the reason it doesn't ruin the augmentation comes down to the depth of the injection plane.
Okay, so the filler isn't sitting superficially on top of the tissue where friction could wipe it away. It's placed deeper into the submucosal layer.
Exactly. The needle bypasses the outer epithelial layer of the vaginal wall entirely and deposits the gel into the structural matrix underneath. It's very similar to getting a dermal filler in your cheek.
Right.
The product is secured beneath the skin, so washing your face doesn't move the filler around. In this case, the tampon rests in the vaginal canal, interacting only with the outer mucosal surface. It doesn't exert the specific targeted pressure that would be required to migrate a cross-linked gel that is locked inside the deeper tissue architecture.
So the filler is safely tucked away, acting as a subcutaneous scaffold, while the tampon just manages the surface capillary bleeding.
Yep, exactly. It's a completely safe way to manage the spotting without jeopardizing the structural integrity of the shot.
Okay, so we've established you can manage the spotting and you can absolutely go back to your desk. But looking at the aftercare guidelines, they clearly show that the lack of systemic downtime does not mean an absence of localized restrictions.
Oh, definitely not.
There are specific activities you are universally barred from doing for the first 24 to 48 hours.
Yeah, and the immediate restrictions all center around two things: infection prevention and minimizing local vasodilation. So clinics strongly advise against rigorous workouts, saunas, hot baths, and jacuzzis.
Because taking a hot bath or sitting in a jacuzzi causes vasodilation, right? Your blood vessels expand in response to the heat.
Yes.
So if you just had a needle puncture an area that's already prone to bleeding, expanding those vessels is just an invitation for renewed spotting and localized swelling.
Absolutely. Heat exacerbates the minor inflammation that's already present from the needle track.
Yeah.
And furthermore, communal water sources like swimming pools or hot tubs, they introduce a massive bacterial load to an area that currently has an unsealed micropuncture.
Yikes. Yeah, that sounds like a bad idea.
Right. Even a microscopic needle wound needs time for the epithelial layer to close over it. Exposing it to heavily chlorinated or bacteria-rich water before it seals is a completely unnecessary risk.
Okay, but this brings us to a massive discrepancy in the clinic materials regarding when a patient can actually resume sexual intercourse.
Yes.
Here's where it gets really interesting. If we look at the instructions from Rotenberg Plastic Surgery down in Miami or Dr. Lazar's clinic in Canada, they state patients can resume sexual activity in just 4 hours. But then, reviewing the protocols from UK clinics like Centre for Surgery or Dr. SW clinics in London, they mandate a waiting period of 5 to 7 days.
It's a huge difference.
I mean, how does the exact same anatomical procedure yield such wildly different recovery timelines? Which is it?
Well, a difference between 4 hours and 7 days isn't just a slight variation in protocol, right? It represents two fundamentally different medical philosophies regarding post-procedure care.
Okay, break that down for us.
So the 4-hour timeline is focused purely on the pharmacokinetic properties of the filler itself. Hyaluronic acid and collagen gels are engineered to integrate into the tissue matrix very rapidly.
Right.
Once injected, they bind to the surrounding tissue water, cross-link, and stabilize. Within about 4 hours, that gel has settled into its new environment securely enough that the physical friction and pressure of sexual intercourse will not physically displace or flatten the augmentation.
So the North American clinics citing 4 hours are operating purely from a mechanical standpoint. They're basically saying the filler has set, the structural work is secure, you aren't going to ruin the shape.
Exactly. The structural risk is mitigated after a few hours. The clinic's mandating a 5 to 7 day wait, however, they are looking at the procedure through the lens of strict wound healing protocols.
Ah, okay. So they aren't worried about the filler moving at all. They're worried about the needle track itself.
Right. They are prioritizing the complete closure of the epithelial layer. A needle creates a microtunnel through the mucosa, and while the bleeding stops quickly, the tissue itself takes several days to completely knit back together and restore its natural barrier function.
That makes total sense.
Yeah, so introducing the friction, bodily fluids, and naturally occurring bacteria associated with intercourse before that barrier is fully restored, it just introduces a variable risk of infection.
So it's a clash between biomechanical stability and conservative infection prevention. One approach says the product is safe, the other says the wound needs to close.
Precisely.
So for you, the listener, navigating this, the ultimate takeaway is absolute compliance with the provider who actually performed your injection, because they know the exact gauge of the needle they used, the specific viscosity of the filler, and the depth of their own technique.
Yes, please follow your own doctor's advice.
Mixing and matching post-care advice from the internet against your specific doctor's orders is just a recipe for complications.
Exactly. The provider's protocol is tailored to their specific technique. Following it ensures the best possible integration of the filler and the absolute lowest risk of localized infection.
Okay, so synthesizing everything we've looked at today, the biological reality actually does support the clinic claims. Because the G-Shot utilizes bioidentical fillers and localized anesthesia, it avoids triggering a systemic immune response, meaning actual downtime is pretty much non-existent. You can functionally return to work immediately.
Yeah, and the localized responses, the spotting from capillary breaches and the mild tenderness, those are just standard physiological reactions to a needle puncture, easily managed with over-the-counter methods like tampons or sanitary pads.
Right. And the physical augmentation created by the hyaluronic acid binding with water, it provides a structural lift that lasts anywhere from 3 to 12 months, depending on your individual metabolic rate, before the body naturally breaks it down and absorbs it.
Yep. The physical volume eventually disappears entirely. The anatomy returns to its exact pre-procedure state.
Yet, looking through the clinical summaries and the patient reports, a really fascinating pattern emerges. Long after the 3 to 12-month window has closed, long after the filler has been completely metabolized and the physical enhancement is totally gone, many patients still report a profound, lingering boost in their overall sexual confidence and satisfaction.
It's amazing. It really suggests the physical intervention acts as a catalyst for a deeper psychological shift.
It does, and it leaves us with a compelling question to consider as we wrap up. Once the biological scaffold has dissolved and the anatomy has returned to baseline, how much of that enduring satisfaction is tied to the physical memory of the change, and how much is just the powerful psychological result of a woman deciding to take proactive, unapologetic ownership of her own internal pleasure? Definitely something for you to think about.